Okay, so my name is Melvin Chin. I'm one of the other medical oncologists at Prince of Wales Hospital. And thank you once again for coming tonight. And I guess just putting it all together, we heard from Winston earlier this evening about the changing demographics and incidence of cancer and the changes in the treatment. And then we heard how complicated some specific treatments can be, such as what Nadine has to use to look after her type of patients, and also how closely related the team is. When you started talking about referring people to an MDT, it's about actually various experts coming together to review the case of that patient to decide for that particular individual what's the best treatment for that person moving through that treatment and looking after them. We heard from David how intractable, and from your own your father's experience, how intractable some of these side effects to the treatments of cancer can be when we get people through potentially curative treatment. When they're finished with it, they still end up with some legacy from those that pass. So I'd like right now for you to think about a particular patient that you have looked after who had cancer. And I reckon before they had cancer, this is your patient, maybe that Robert at the age of 50, he had his life as an accountant, all these little other things in his life, some distant, some he's actually interacting with right now. And the hospital is something he had an appendix operation in many years ago, but he's seeing you as a GP every now and then. And then the diagnosis of cancer, the life suddenly changes, the perspective changes, everything else becomes a secondary issue. And as a GP, you're dealing with the fact that this patient has a fecal occult blood positive, positive thing, and also potentially a colonoscopy and a CT scan that said something bad was suspected there. And I think that red arrow, trying to get them into one of those MDTs, some expert in the hospital to look after this patient, because it's kind of beyond what primary practice, primary care can offer at that time. And then this patient gets absorbed by the hospital. He goes in there, and you've delivered her like a little baby that you left at the orphanage, isn't it? You suddenly become apart from this patient because this patient becomes part of the hospital. The fuss, all the MDT, the care coordinator, the dietitian, 100 different people, moving parts, and the cancer is the major focus. That's why that person is in hospital. And then the treatment ensues. This is now the 6th month of treatment, successful. Everything seems to be in remission. Things look good. There's a bit of neuropathy. But that excitement, that original fear of the cancer is now subsided. But this patient is very, very much part of that hospital ecosystem. They're very reliant. In fact, they think the hospital has saved their life. And there's this dependence that has you're far away. You're in the corner there because you'll be maybe getting a letter every now and then. You're like, dear mom, I'm fine at camp. Everything's going well. And then months go on, and the cancer becomes an afterthought for most of the time until they come back to see Winston and David for their 6-monthly scans. And then they get this spike in adrenaline and fear that maybe at that time they'll have the bad news. They have sleepless nights times before. But as Robert did, he's eating his McDonald's and KFC, and he's putting on weight. And he may have a partner, but he's having problems with sexual function. He doesn't tell David, he doesn't tell Winston, he doesn't tell me. Because when we see him, he just wants to know whether he's cancer-free or not. And there doesn't seem to be time to discuss all these other things in his life that matter to him. So Winston showed you this increasing incidence of some cancers and plateauing, but with decreasing mortality. So the number of people on the incidence per 100,000 there and the years following, we're starting to see this widening gap, because as patients survive and then we're also diagnosing more of them, the clinics get busier. And in the existing models of care, these patients keep coming back for hospital-based appointments, but they don't necessarily need all of our expertise anymore, the way that they did when they first came to meet us. And as we have this increasing numbers, we clog up our clinics with people that might probably need less time from us, and that we should spend more time on the patient that we first met. And I think what also happens is there's this fragmentation where perhaps some of the things you have to deal with more and more as the patient transitions out of their cancer trajectory, but then you're not getting the full story. So there are things that the oncologist might not want to deal with, and then there are things that the GP might not want to deal with, and then the person's sort of like trapped in this nowhere land. So I was going to tell you about something that Mark and I have been doing since about middle of 2013, and we've had the input of new team members from about 3 or 4 years ago. We were commissioned to look at how we could decongest our cancer clinics by perhaps finding a model by which we could shift patients who no longer needed that highly specialized care out of. So in other words, maybe a protocol that we can give GPs that they can help look after patients. Mark said, no, we shouldn't do that. We should actually find out whether this is the right thing to do first or not. And we commissioned a qualitative study which I'll show you the results in just a moment. And out of that qualitative study, we decided we potentially had a solution to this problem that we were observing. And we've spent the last 2 or 3 years working out these details, and we're about at the cusp of piloting this potential solution. And during that time, we've also had a couple of tranches of funding through the TIC, which is a local health district initiative, as well as from the Cancer Institute. So that qualitative study was a interview of patients who had completed treatment for breast and colon cancer, and they were interviewed, and so were their GPs and their oncologists. So what we did was, the patient are the blue circles, the GPs were that hexagon, the oncologists were that yellow squares. And essentially, through these patients, we asked their GPs if they would be interviewed, and then we also interviewed oncologists, which would have looked after quite a few of these patients. And we found that we had 22 patients with 18 GPs that said yes to the interviews, 16 specialists, and moreover, we were able to actually see them in the clusters. So we actually had people in dyads, triads, quartets, and pentads. And essentially, what we found from that study in summary was that the patients valued the reassurance from the expert care that they received, but they also they wanted GPs to be involved in addition to specialist care, but not instead of. So it was very difficult for a patient, which I described a scenario to you, to suddenly transition out of the cancer center in that way. GPs, on the other hand, recognized they somehow lacked that training, the protocols, and that access back in, because it's well and good that we're looking after the patient, but what if there is a problem? What do we do? So I think the answer was that there needed to be this working combination between the specialist and the GP to help look after the patient. So we came up that perhaps a long-term shared model, which is individualized to each patient, not a pro forma. This is what this group says we should do, but rather specialized and individualized to that particular patient's risk factors was perhaps the way forward. So we know from many studies that general practice follow-up for patients with cancer is not inferior to specialist follow-up, and that's been demonstrated on a range of different studies. And this particular sort of like a meta-analysis by Yan Zhao and the group actually looked at a lit review that found that patient satisfaction is actually higher when GPs and specialists share care, and in terms of outcomes there is actually non-inferiority. So these are the models of sharing care at the moment. One is a transfer of care, the original model we wanted to implement. So we write you a template of what you should do as we discharge the patient to you. But even worse than that perhaps is that, goodbye, I don't need to see you anymore. If you have a problem, go see your GP, which also happens as the other way of transferring care. There's also other models tried, for example, the preceptorship model where GPs go into a training program to upskill in feeling confident in the knowledge of how to look after patients with different cancers. You get, I guess, an association usually with a cancer center that has organized that preceptorship, and you've got like a preferred status. You know, you are the GP that we recognize as having those skills. And it has its pros and cons for that model as well. But what we wanted to do was we recognized the pros and cons of all these different models, and based on the earlier qualitative study that we did, we came up that perhaps the solution to share care is so that in a way that we can actually exchange information between the specialists and the GPs. Perhaps that's the solution. So that was our bright spark that came out of that first 3 years of trying to find that solution. And we this is the diagram for it. We'll have a cancer shared care plan that sits somewhere that GPs with your medical director, with your best practice and any other software that you use, and then the medical oncologist and all the other members of the team using whatever software is in the hospital is able to meet in this middle where we have this web-based application, and we can even feed it out to My Health Record or some other portal, maybe a login for the patient to see what's in their own health record. So we thought, we've cracked it, we found the solution, yeah? We've just going to go to the funders, we're going to New South Wales Health. This is part of your integration plan. We've read it through the integration plan of the health district, and in fact New South Wales Health, surely they're going to give us money for this project, yeah? But no. Unfortunately, there's been carcasses of similar programs over many years where other groups have tried implementing, getting millions of dollars to create bespoke programs exactly to do this thing, and have failed because people either don't use them, or they failed the endpoints, or there's some technical failure, people can't log in, and people give up. And surprisingly, despite what's said in health district policies, etc., breaking through that wall as an outsider, as a GP who's not got one of these passes with a unique staff number, is anathema to the IT system managers of the hospital. They just can't even think how they can give somebody who's outside of the health